Okay, good evening, everyone. I'd like to welcome you all to tonight's MSIG webinar, where we're continuing the series on textbook injuries, where each speaker is going to share their expertise on a specific sport and identify the most common injury or injuries from that sport. So it's an honor to have the following AMSSM members serving as the speaker panel tonight. We have Dr. Marcia Faustin and Dr. Ellen Casey, who each give presentations on women's gymnastics. Dr. Torrance Laury will give a presentation on men's gymnastics. Dr. Stephanie Aldret will give a presentation on trampoline. And Dr. Emily Sweeney will make a presentation on her research study on spondylolysis. My name's Lauren Prisco, and I'm the MSIG president, and I'll be serving as the moderator for tonight's webinar. I'm currently an M4 at Weill Cornell, and I'm applying into family medicine. And so after all of our speakers have shared their presentations, I will moderate a Q&A. So during the webinar, you can enter your questions in the chat, and then I'll read the questions at the end after everyone's presented. So now it's my pleasure to introduce Dr. Marcia Faustin. Dr. Faustin is a family and sports medicine assistant clinical faculty physician at the University of California, Davis, under both the Department of Physical Medicine and Rehabilitation and the Department of Family and Community Medicine. She serves as the co-head team physician for UC Davis Division I Intercollegiate Athletes, co-head team physician for USA Gymnastics Women's National Team, team physician for Sacramento Republic FC professional soccer team, and multiple Sacramento area junior colleges. Dr. Faustin has a particular interest, both clinically and in the research realm of mental health, female and male athlete triad, and relative energy deficiency in sport and adolescent medicine. She also enjoys teaching and mentorship of medical students, residents, and primary care sports fellows. Both of her parents emigrated from Haiti, so she grew up speaking French, which was useful for the Paris Olympics. Dr. Faustin, you can proceed with your presentation now.
Thank you, Lauren. Thank you, Lauren and Joan, for putting together this awesome series. I'm honored to be invited to be here along with my amazing colleagues that work with USA Gymnastics. So today I'll be talking about the common injury in women's artistic gymnastics, the distal radius epiphysitis. I'm giving throwbacks for Dr. Torrance Laury, can you guys see my mouse too? Yeah, okay. Who's pictured right here, who you'll have the privilege of hearing later. My amazing co-head team physician, Dr. Ellen Casey, who will also be presenting later. And then this is Dr. David Cruz, who was our prior men's team doc and medical director. And so this was us when we were at the Olympic trials in 2021. And then it was fun to put this together because this was us just a couple months ago at the Olympic trials for 2024. I have no disclosures. I'm sure a lot of you got to watch the Olympics. Dr. Casey and myself got to be there and watch these women do amazing. And our objectives today in these 10 minutes are, number one, to introduce to you how I got involved in gymnastics. We'll review the biomechanics of the wrist, discuss distal radius epiphysitis, go over that history and exam, and then what that treatment plan looks like. Here's Dr. Casey and myself. Goodness, I can put her in like thousands of pictures, but I'll spare everybody a few. But this is us when we were at the Olympic Village in the clinic in Paris just a couple months ago. So how did I get to working with USA Gymnastics? So I have to take you back to 1992, when my three older sisters and I were watching the 92 Olympics and we saw Dominique Dawes and our mouths dropped. We just couldn't believe there was somebody that looked like us that was on television and doing gymnastics. And so that's when I got exposed to the sport and loved it so much, did it all the way through high school along with volleyball. But track actually turned out to be the sport that I was most talented at. And so that's what I did in college. Now, pictured below here is Dr. Neeru Jayanthi, which I'm sure many of you have heard speak or read his papers. He's been an AMSSM member for a long time. And when I was at Loyola Chicago, he was my team physician. And he was looking at my knee or something, and I asked him, "What do you do?" And so he said, "Come with me." He took me to clinic for family medicine, took me to the hospital, he took me to resident teaching, and that's where I realized that I wanted to be a family medicine, sports medicine physician. And so he started to plant that seed. And then I went to UC San Diego for family medicine residency and then stayed there for fellowship. Pictured here are all my co-fellows when we went on a golf outing. I was horrendous, but during that experience, I had a lot of great mentoring and knew I wanted to get involved in some way with gymnastics and was able to rotate with different physicians and give myself different exposures to be able to do that. And then in 2019, Dr. Casey and myself took over taking care of the team, and we got to do it together. Moving on, let's go to the biomechanics of this. So as many of you probably know, because you watch the Olympics, women's artistic gymnastics has main. It starts with vault, where they run down the vault runway, hit this board, hit the vault, do a couple flips and land. Then we have bars where they're going around the top bar and the lower bar, and then they release and do a dismount. We have beam, which they're on their legs or they can be on their hands for this. And then we have the floor exercise, which usually has the floor routine with music and lots of tumbling. And so in order to talk about what we're going to be doing with our distal radius is we have to talk about the wrist motion. So if I know I can't see everybody, but you're taking your wrist, your hand right here. And when you lift it up, we're going into dorsiflexion or hyperextension of the wrist. And when you come down, we're in palmar flexion. So you can do it with me. So the injuries that occur with this particular injury is because you have repetitive dorsiflexion forces that are occurring on that wrist. And so you can see this female gymnast right here who's doing a handstand. And you can see that there are forces that are axial forces, compressive forces, and torsional forces that are occurring on that wrist. And that's where we have those injuries occur. So if you see somebody in clinic, maybe a 13-year-old female comes in and they're saying that they have distal radius pain, typically in dorsiflexion, verbatim, just joking. But usually they're coming in saying they have some wrist pain. A lot of times it's really with that wrist motion and dorsiflexion. But if it's been chronic in nature, it can be with flexion also, with palmar flexion also, or maybe they're just having it at rest or carrying their books or doing everyday activities. On exam, we're looking at the wrist and we're comparing the affected side and the unaffected side. So you want to know, is there swelling of the wrist? You want to know where they're tender to palpation, right? And we want to be very distinct about, it's usually at the distal radius, but we're palpating other areas because we have to rule out other diagnoses, such as your distal radial ulnar joint or your carpal bones. Then we look at range of motion. Typically on exam, they may have limited dorsiflexion and palmar flexion. The other motions of the wrist are also, though, we go for supination or pronation. I know you guys are doing it with me. And then radial deviation and ulnar deviation. And so we have to test all those range of motions and the strength in order to see what is affected with that. Now, the other important thing, which I got from Dave Tilley, who owns the Shift Movement Science, is this picture right here where we're looking for shoulder range of motion. And so this is a seated wall angle test. You have them put their back against the wall and make sure that their bottom is also hitting the wall. And then you bring their arms up and you want to know, are they able to get their full shoulder range of motion? Because if not, then what happens is they can end up loading the wrist even more so because they're compensating for the limited range of motion of the shoulder. Now we're going to do a little bit of basics before I go into that imaging and looking at the anatomy. And so the mnemonic I like to use is MD. Sorry for the DOs, but this is the one that I can remember. So when we're looking at the bone, we know that metaphysis is the end and the diaphysis is the shaft. So there's your MD. Now for pediatrics, they are the early MD. That's how I remember it. So you have their epiphysis and then your metaphysis. In between those two areas are your physes or your growth plate. This is critical for all of our pediatric patients for whatever pathology you're looking at. Then you have your diaphysis. So everybody now knows pediatrics, early MD, right? And the growth plate is the main place that's going to get injured. And then you have your MD. So when we look at these radiographs, what we can see is you can see widening of our distal radius in this region. And then usually on the volar aspect, so on the palmar aspect, you can get also widening of that growth plate that you can see on the lateral view. Now, you can also get an MRI. This is a T2 image because we see that fluid is bright white, that H2O for T2. And what you can see at that distal radius at the growth plate is that there's inflammation with the white area right here, and there's widening of the growth plate. So this is distal radius epiphysitis, or what we call the gymnast wrist. And the incidence, what they're saying is about 25% of non-elite gymnasts, although wrist pain can affect about 88% of all gymnasts. It's typically in their adolescent years, although we can see it earlier. And usually if they're doing gymnastics more than about 35 hours per week, although it depends how much they're loading on that wrist. And gymnasts are using their hands, and they're just like their feet. And so there's a lot of force that's going through the wrist. And the forces themselves can exceed about 2 times the body weight. And the load itself can be up to 16 times the body weight. So that's a lot of force that's going on that wrist. And the physis is prone to injury because, just to always remember, the growth plate is the weakest point of the bone. And so that's where the injury will occur. There's 2 theories about how this happens, whether it's 1, they're getting multiple microfractures of the physis, or 2, they're getting temporary ischemia or loss of blood flow to the physis, and then that will cause the widening. So how do we treat this? The goal is to rest and avoid painful activity. You typically want to immobilize for about 6 weeks or so, but at least until they're pain-free. Some people will cast them. Others will put them in a wrist brace, whatever it is that you need to do or you feel most comfortable with. If pain is severe and they need oral pain medication, typically like to start with Tylenol, or you can do NSAIDs as needed for short term. And then next, you want to get them into physical therapy. The goal is to focus on the wrist and the shoulder range of motion and strengthening. And the overall goal is to decrease that load on the wrist. So one thing they have within gymnastics is tiger paws. And these are the wrist braces here. I didn't know they had all these colors, but I would definitely have the pink one. Nonetheless, what it stops is it helps to limit dorsiflexion so that we can decrease the load that's on that distal radius. So they can use them on beam, floor, and vault. And then bars, they cannot use them because they use grips, which they're using to hold on to the bars. Thank you. This is Dr. Casey and myself from the Olympics, and a picture from the Paris Olympics, but this one that she probably has in hers too, maybe, is who did it better, which we always think ours is clearly better. And that was from Tokyo 2020. Clearly we're masked. And this is just a funny picture of Dr. Casey and Dr. Laury and myself, because we rarely get to be in the same location together, but we'll always get on a FaceTime and laugh to decrease the stress. Thank you for having me.
Thanks so much, Dr. Faustin. That was a great presentation. I love the photos at the end. So now we're going to move on to Dr. Ellen Casey. So Dr. Casey is a professor of physiatry at the Hospital for Special Surgery, HSS, and Weill Cornell Medical College. She is the Susan Wagner and Neil Leonard Endowed Chair of Physiatry Research and is a member of the Women's Sports Medicine Center at HSS. She has expertise in the female athlete, including the female athlete triad and relative energy deficiency in sport, and musculoskeletal conditions during and after pregnancy. Dr. Casey has served as co-physician for the USA Gymnastics women's national team since 2019 and has cared for Team USA at the Tokyo and Paris Olympic Games, as you saw those photos. Dr. Casey is actively involved in sports med research, and she is interested in the underpinnings of sex and gender disparity in musculoskeletal injury and injury risk reduction in gymnastics. So, Dr. Casey, you now have the floor.
All right, wonderful. Thanks, Lauren. Can you guys just confirm you can see the slides and hear me okay? Perfect. All right. Well, I should have gone first because some of my pictures are, going to be repeated here. Some of Dr. All right. And we were asked to start with saying how we became involved in caring for gymnasts. So I first was introduced to the sport of gymnastics through a dance class. So this is me in preschool, probably the first time I was on the balance beam. Although I didn't actually officially start the sport of gymnastics until many years later when I was 9. I had the good fortune to be able to continue my gymnastics career through college, and certainly the experiences of being a student athlete led me to the field of sports medicine. My route was to get there through physical medicine and rehabilitation. I trained for residency and fellowship in sports medicine and interventional spine at Northwestern. And as you saw, Dr. Faustin and I have been able to take care of USA Women's Gymnastics since 2019, including support them both in Tokyo and then more recently in Paris. And the reason we're talking about Achilles tendon ruptures is because women's gymnastics, particularly collegiate gymnasts, have the greatest risk and the greatest rates of this injury. And it's interesting to know this because typically when we study Achilles tendon ruptures, we hear it's more common in male athletes, and we think of basketball players, especially like the weekend warrior. But actually, if you look at the numbers from collegiate gymnastics, you can see that women's gymnastics has a fourfold greater rate of Achilles tendon ruptures compared to men's basketball, which is the next most common. The only other women's sport that even makes it on this graph is women's basketball, and then you kind of go down for men's track and cross country and men's football. So it's a big problem in terms of the sheer risk in women's college gymnastics. And actually, the numbers are likely higher than what we know from the papers. So there was a survey done a couple years ago where athletic trainers who take care of women's gymnastics were surveyed about the rates of this injury from 2013 to 2018. And they found that there were 71 Achilles tendon ruptures, so approximately 12 per year. If you actually follow social media or some websites that actually collect injury data unofficially on women's gymnastics, it's probably higher than that. So there were 20 in 2020, and so gymnastics is a winter season. So because of COVID, there were only 2.5 to 3 months of the season, and there were still 20 athletes who ruptured their Achilles tendon in the beginning of the season before it was cut short. And then there were 15 or 16 in the last few years. So some of the biomechanical factors that probably play a role in why this is such a higher risk in women's gymnastics are sort of the flip side of what you just heard Dr. Faustin talk about in terms of the high loading and impact forces. And in this case, that's occurring at the foot and the ankle. So when gymnasts are doing work on floor or vault, specifically, if you see down here, hopefully you can see my mouse. So this is a static image of a gymnast doing a round off back handspring. And here she's punching or taking off from the floor. Her foot and ankle is in dorsiflexion, and then there's some type of flipping or twisting maneuver that she'll do. In that maneuver, she will have 15 to 23 times her body weight absorbed at the foot and the ankle, both from the takeoff and the landing. And if this dorsiflexion angle is greater, or like a shorter position in landing is what we call it in gymnastics, and you can see similar dorsiflexion position here hitting the springboard for vault, those impact forces are likely to be even higher than what was collected in biomechanical studies. So it can be a significant amount of load. In addition, gymnasts are known for doing a lot of repetitions as well as high loading. So if you look at this 2x2 chart that we just put together, kind of comparing different types of athletes, you've got your, maybe couch potato person who's having low repetitions and low loading to their Achilles tendon. You may have your cross-country athlete that has high repetitions, but fairly low loading. And they are very unlikely to get Achilles tendon ruptures, though they do get a decent amount of Achilles tendinopathy. You may have your basketball player that does have a lot of high load, but maybe not as many repetitions. And the gymnast is sort of in that kind of upper, right quadrant. That's the perfect storm with the early specialization that gymnasts are known for, the year-round training, and the Achilles tendon takes a lot of load over a long period of time. When we think about the history and physical exam for Achilles tendon ruptures, the nice thing about this is it's fairly easy to identify this as an injury. Unfortunately, we all of those on this call have seen this injury happen. It happens very suddenly. As I mentioned, in gymnastics, it's often on backward tumbling and the takeoff for a tumbling pass. And the athlete might not be able to complete that tumbling pass or have a very low landing due to the fact that their Achilles Achilles tendon ruptures in the takeoff. They might say, I feel like I was kicked in the back of the calf, or we've had athletes say it feels like something's gone, it's missing. They may report a pop. In gymnastics, this occurs more often in competition than in training situations. And then when you ask them if they have this happen, did you have any pain prior? Many of them will report a prior history of Achilles tendon pain, although not all of them will. The physical exam, again, is pretty straightforward. You kind of recognize it before you even examine the athlete. But if you were to inspect their calf and tendon area, you might see what looks like a kind of a very hypertrophic calf or bunching of the calf musculature in the tendon as it retracts after it's torn. You certainly would be able to palpate a defect if it's a complete rupture, so you can palpate along the tendon and then all of a sudden you're not feeling that continuity. If you did check their strength, they would have weakness with plantar flexion, which makes sense as that's the role of the Achilles tendon. And there's a couple special tests that you can use, one of which is shown here in this graphic, which basically this is called the Thompson test. And so what you do is you have the athlete lying prone or sort of kneeling with their foot off of an edge. And if you squeeze their calf, if the Achilles tendon is intact, they will do a passive plantar flexion at the ankle. If the Achilles is torn, there will be no motion at the foot. Because of what I mentioned, this is such an obvious injury oftentimes, this really is a clinical diagnosis, and you don't need advanced imaging to tell you what's going on. But oftentimes you do get advanced imaging to confirm what's happening and also probably to make some informed decisions about surgical techniques. And most people will use an MRI, which in this case you can see marked here by this orange arrow, and what you have is this bright white signal between the tendon pieces. So the tendon should be very thick, dark gray or black, and the white there is where you have the edema as well as bleeding that can happen in acute rupture. You can also use musculoskeletal ultrasound, and you can see the defect there as well. Musculoskeletal ultrasound is great to look at tendon in multiple different facets, but both MRI and ultrasound can be used in this case. Achilles tendon ruptures are tough because they take a long time to return to sport. So most, if it's a gymnast trying to return to high-level sport, will have a surgical repair. Usually gymnasts are not back until about 9 months, but we say about 6 to 12, and not all of them can return to their prior level of sport. So 61% of college gymnasts reported in a study we did returning to sport, but only 59% thought that they were at their prior level. And in some cases, it can be career ending. And unfortunately, some athletes have this happen on one side, the other side, and even there have been a few college athletes that have had it happen even more than 2 times. So, most of us on this call are pretty committed to reducing the risk of this because it's so much more prevalent and common in women's gymnastics. And we definitely want to reduce some of the modifiable factors once we can identify them. And that would include things like monitoring and modifying training load. And then, of course, looking longitudinally to see prospectively if we can make any interventions to reduce the risk of this injury. And I'll leave you with 2 newer pictures that Dr. Faustin did not show from Paris, but this is our medical team, men's and women's, for the most part. And thanks so much for your time tonight.
Thanks, Dr. Casey. That was a good presentation as well. So just to keep things moving along, I'm going to move on to Dr. Laury next. So Dr. Laury competed in gymnastics at the junior elite level and through college at the University of Michigan. He completed his medical doctorate degree from the University of Michigan, followed by a family medicine residency and sports medicine fellowship at Emory University. Dr. Laury currently works at Northside Hospital Orthopedic Institute in Atlanta, Georgia, where he also serves as the Associate Director for the Northside Hospital Sports Medicine Fellowship Program. Dr. Laury also works with USA Gymnastics as the men's national team physician and served as the men's gymnastics Olympic team physician in Paris, France. He enjoys doing adult gymnastics, hiking, running, and spending time with family and friends. So now, Dr. Laury, you can have the floor.
Thank you so much for having me. Can everyone see my slides? Perfect. So we'll go ahead and get started. So now we'll talk about an injury that we see commonly in men's artistic gymnastics, which is OCD of the capitellum or osteochondritis dissecans of the capitellum. So I have no disclosures to disclose. And a little bit about myself. So I started gymnastics when I was 6 years old and then stuck with the sport, competed through college at the University of Michigan. And back in 2021, took on the role as the USA Gymnastics men's national team physician and had the honor of serving as the men's Olympic team physician in Paris, which was a huge honor. So it's truly been a privilege to be able to give back to the sport that has given so much to me. So just a little bit of background regarding men's artistic gymnastics. So there are 6 different events: pommel horse, rings, parallel bars, floor, vault, and high bar. And as you can see from this diagram, 4 out of the 6 events are predominantly upper extremity events. So the pommel horse, the rings, parallel bars, and high bar are predominantly involving the upper body. So we do see a greater proportion of upper extremity injuries in men's gymnastics, including the OCD of the capitellum. And even on vault, though, even though that is typically thought of as a predominantly lower body event, you can see from this diagram as the athlete is propelling himself off the table, there is a significant force that is flowing through the upper body as well. So really 4.5 out of 6 events are upper body predominant in men's gymnastics. So that's why we do see a high prevalence of upper body injuries. So just moving on to OCD of the capitellum. So what is it? So going over nomenclature, OCD stands for osteochondritis dissecans. So osteo meaning bone, chondral cartilage, dissecans meaning separation. So looking at this diagram here, you can see this glossy white shiny surface. That is the articular surface of the elbow. It's composed of hyaline cartilage. And then this is the humerus, and then you have the radius and the ulna. So these bright white surfaces are the articular cartilage. Just beneath that is called the subchondral bone. So an OCD is an injury to the articular cartilage and the subchondral bone, and it can separate from the surrounding bone, which is how we get the term osteochondritis dissecans. And just to review a little bit more anatomy, so we have the medial aspect of the humerus, we have the lateral aspect of the humerus. At the anterior aspect of the distal humerus, we have the capitellum. And then we also have the radial head, so this forms the radiocapitellar joint. So in gymnastics, when you have that repetitive upper body weight bearing, that can lead to repetitive microtrauma. And the capitellum at baseline has a poor vascular supply, so with that repetitive microtrauma, you can have an impaired vascular supply, further vascular compromise, which can lead to ischemia and ultimately an avascular necrosis of this capitellum. We do see it fairly commonly in gymnastics, but we also see it in overhead throwers as well as weightlifters. It's a little bit more common in adolescents, and it's a little bit more common in boys compared to girls, but I have seen quite a few female gymnasts with OCD of the capitellum as well. A little bit more about the biomechanics. So you can see from these diagrams that in gymnastics, there is a significant load on an extended elbow or sometimes even an hyperextended elbow. And in this diagram here, you can also see that there's valgus loading of the elbow. So when you have a valgus force, you have tensile forces on the medial aspect of the elbow and compressive forces on the lateral. So when you have that repetitive compressive force on that capitellum, that can predispose one to developing an OCD lesion. So in terms of the clinical history, so when an athlete presents to my clinic with an OCD lesion, they'll often report a gradual onset of pain, and it's typically located in the lateral aspect of the elbow. They may have some swelling, some stiffness, some loss of terminal extension and flexion. And if it's severe, if they have a loose body that breaks off and detaches from that OCD lesion, they can also develop mechanical symptoms, including clicking, locking, catching. They may even have some instability where they feel like their elbow joint gives out on them. For a physical exam, it's always important to start off with inspection. So you may inspect some lateral elbow swelling, and then moving on to palpation, they'll have some tenderness at the anterolateral aspect of the elbow, right over that capitellum. They may also have some crepitus or a crunching or grinding sensation with pronation and supination. And then it's important to assess the range of motion and strength. So range of motion, including flexion, extension, pronation, and supination. And a hallmark feature is a loss of terminal extension with OCD lesions. And then you also want to assess their strength in all of these planes as well. And then there is a special test unique to capitellar injuries called the radiocapitellar compression test. So that is when the patient extends the elbow and then actively pronates and supinates against an axial load applied by the examiner. So a positive test is a clinical indicator for a possible OCD lesion and an indication to get some imaging. So with imaging, we start off with x-rays. So a good proportion of x-rays are actually going to be normal, but when we do see an OCD lesion on x-rays, we do see a lucency right here at the capitellum. So we said this is the capitellum, the radial head, and then you have this dark lucency right at that capitellum, and that is indicative of an OCD lesion. You may see some flattening, you can see some fragmentation, as well as maybe even some sclerosis of the surrounding bone around the lesion. This is an example of an x-ray from a 12-year-old male gymnast who presented to my clinic with a 1-year history of lateral elbow pain. And this is his MRI here. You can see this is the capitellum, the radius, and then this is that OCD lesion. His was relatively large at 9.2 millimeters. And MRIs are very helpful in assessing the size of the lesion as well as the stability of the lesion. So stability determines whether or not a lesion is predisposed to detaching. So a stable lesion is one in which the articular surface is intact. An unstable lesion may have a rim of fluid around the lesion and some involvement of the articular cartilage, and that is prone to detaching. You can form loose bodies and fragmentation as well. So an MRI is really helpful at determining the stability of the lesion, which can help to determine the management as well. An MRI is also really helpful at assessing for any associated ligamentous injury as well, specifically that UCL on the medial aspect of the elbow. In terms of management, so this is determined whether or not this is a stable versus unstable lesion. So for stable lesions, we do a trial of conservative measures. So this includes resting from loading that elbow, so relative rest. If the symptoms are severe, you can consider immobilizing in a hinged elbow brace from anywhere between 1 to 6 weeks, depending on the severity, but most people do well just with resting from impact. And then also doing physical therapy, really working on obtaining that terminal range of motion, that full flexion and extension, pain-free pronation and supination, and then also working on strengthening as well as some soft tissue treatments as well. And then once they've rested for about 3 to 6 months, you can consider allowing them to gradually return back to sport as tolerated. You may want to get serial x-rays every 6 weeks or so to assess for radiographic healing. And it may also be beneficial to get a repeat MRI at either 3 months or 6 months to assess for radiological healing before allowing them to return to sport. For unstable lesions, these require surgical management, which can include excision, debridement, filling of the defect. Other indications for surgery include loose bodies, mechanical symptoms, loss of terminal extension, closed physi. So an open growth plate is a good clinical indicator for potential for healing with conservative measures. But if the growth plate is closed, then that is an indication for surgical management. And then also failure of conservative measures for 6 months is another indication for treating this surgically. So once they've gone through their period of relative rest, physical therapy, then we do, I mentioned the repeat radiographic and radiological assessment, but you also want to do a repeat clinical evaluation. So you want to make sure that they've obtained full range of motion, good strength, resolution of swelling and tenderness, and then you also want to perform functional testing in the office. And this is an example of a good functional test that's specific to gymnastics. It's called an L-seat. So you can see that the athlete is loading that elbow in full extension, and if they're able to do this without pain and they meet those other benchmarks, then you can allow them to gradually progress back to gymnastics. And these are my references.
Okay, great. Thanks so much, Dr. Laury. That was a great presentation as well. So now we're going to move on to Dr. Aldret. So yes, yeah, Dr. Aldret. So Dr. Aldret is a graduate of Oklahoma State University College of Osteopathic Medicine in Tulsa, Oklahoma. She completed an internship and residency in family medicine at Oklahoma State University Medical Center, as well as a fellowship in sports medicine at the Edward Via College of Osteopathic Medicine in Blacksburg, Virginia, where she served as one of the team physicians for Virginia Tech and Radford University. She is board certified in family medicine, osteopathic manipulative medicine, and sports medicine. She currently serves as the chair and associate professor for family medicine, osteopathic neuromuscular medicine, and sports medicine at VCOM, Louisiana. Dr. Aldret serves as one of the team physicians for the University of Louisiana at Monroe and USA Gymnastics, trampoline and tumbling, and parkour. She has provided medical care for multiple Paralympic Games with the USOPC, as well as local events for secondary schools, universities, and recreation events in Louisiana and Oklahoma. With her role with USA Gymnastics, she has served as medical director to premier domestic trampoline and tumbling, rhythmic, and acrobatic events. She was able to provide care for the Team USA trampoline gymnasts at the 2024 Summer Olympic Games. So now you can take it away, Dr. Aldred.
All right. Thank you very much, Lauren. Thank y'all for having me here too. For me I appreciate having our trampoline gymnasts included in this presentation as well. We had one day of competition at the Olympic Games, and that it seemed like it started pretty early with it too. So for me, that I'm kind of a hodgepodge on this because I didn't have any time in gymnastics growing up or anything like that. That I did a little bit of tumbling. I was more of a cheerleader, and that after going through and cheering at University of Oklahoma on the all-girls squad for a year, I found my pathway to sports medicine and was working as a student athletic trainer at that point, and finally decided after a couple of years working college football and then also collegiate cross-country track and field that I was ready to go to medical school. That I liked the hands-on aspects of everything, and so that's where I ended up going the osteopathic route, and I've loved the manipulation and everything else that's gone along with it. Then I went to OSU, did family medicine at OSU, and then did my sports medicine fellowship at VCOM, Virginia. That after I'd been in practice in South Louisiana for about 3 years, I had applied for the USOPC's volunteer sports medicine rotation, was accepted for that. And during my time for my 2 weeks in Colorado Springs, Trampoline and Tumbling was doing their Elite Challenge, which was their big event. That they liked the fact that I had background and coverage of college sports in South Louisiana, that I lived in South Louisiana, that I'd covered hockey and rodeo, that I seemed like I was a good fit to be able to cover, have the courage to cover trampoline and tumbling as well. And so that many of our injuries are going to end up being high impact things, that I was trying to go with the less gore to go along with that, because gratefully we end up having some pretty clean camps with some good things. So again, that here we'll talk about trampoline. All right. That here's our trampolinists that were in Paris, that we had two. We had one day of competition, that we had two alternates as well that were there, that I don't have them pictured here. But that is going to be the one picture of me that you end up seeing on this. The one picture from Paris, where I'm back there in the corner, evidently on my phone. Wish I would have put it down a little bit more. But anyway, our male and our female representative and their personal coaches that were there as well. That trampoline, I've got a little video to talk about this, but here's both Jess and Alexi doing their thing across in the trampoline. That here, I'll let this video play. Hopefully it doesn't give us the little ad. Now you can tell that that video was made more for the general public, but that really gives a good idea of, you know, what the sport is, where the scoring and everything else comes from, and that you're counting down, holding your breath for all 10 skills. That they do end up having some upper extremity injuries. Those are typically going to be more traumatic from falls or foosh injuries. That they can also end up having shoulder dislocations as they're trying to really reach to be able to get their height, and typically anterior dislocations there. Really, the main thing I'm going to end up talking about is going to be lower extremity injuries, particularly peroneal tendonitis here. Now, the thing is, they go high. They go really high, as high as two African elephants, but I'd probably end up looking at that as 20, 30 feet above the ground. That where the mechanics end up being an issue is whenever they make contact with the trampoline bed, and they end up getting this eversion, this forced eversion at their ankles because of the contact there that causes a pinching on the lateral aspect of their ankle. And so as they go to take off, well, those peroneals and gastrocs and Achilles are all going to fire in order to help propel them out of the bed too. But they've got this repetitive plantar flexion, dorsiflexion with eversion that happens too. And so they do have trampoline shoes on, which give them a little bit more sticky coverage, a little bit more grip to be able to have onto the trampoline bed, but it also helps to end up protecting their feet as best as possible from calluses or anything else from that standpoint. And so here that contact with the trampoline bed. Now, we can end up seeing how far the bed can end up depressing. That on the right side of the trampoline, on the right side of the images here, that we have somebody that's going to be mid-routine. And so here his feet are a little bit further apart. Then if the further their feet are going to be, that the more pressure, the more pinching that there may end up being on those lateral aspects of their ankles with it too. That they'll also be prone to different back injuries, maybe not necessarily from this, where they end up landing on their stomach on the trampoline, but more from that bounce out, that where they have to stop with a final bounce and hold it for 3 seconds. And so they have all this energy that's come up off of the trampoline after performing those 10 skills, that they have to stop it all of a sudden. And so they are prone to different spondylolyses, spondylolyses there too. But I know that's what Dr. Sweeney is going to end up covering as well. So here, looking at these foot mechanics. Now, of course, we have different misses that can end up occurring, that they fall off, that just project right off like a missile from the trampoline. Good thing they all know how to fall. They all know how to land from there and land safely, and there's plenty of protected mats all the way around. That this poor unfortunate individual here, that she probably landed and was rotating back. This wasn't anything where her initial contact was on the back of her head and neck. And then there's also times where legs can slip between those springs. And so we will end up carrying tourniquets, blood stop, in case there is something of open femoral fractures or anything else along that standpoint, subtalar dislocation with the bed, and the amount of bouncing that they'll end up doing before, and then what they'll end up taking off and settling in between. And so there's lots of movement back behind this lateral malleolus, and these peroneals really are working hard in order to help to stabilize and work against the different forces. And so with this sliding behind the lateral malleolus, that they can end up getting pretty good inflammation and tendonitis across there, and end up coming to us with a pinching sensation, pain across the posterior side of that lateral malleolus down to the foot, but then also the pinching sensation with every time that they're bouncing up and down. And so this can really end up being more nagging than anything else. But depending upon the amount of inflammation, how hypertrophied those peroneal muscles, both the bellies of the longus and brevis and tertius, can end up becoming, may end up preventing how much they can slide and glide with the tendons across these retinaculums, or that they just end up staying in a state of spasm, continuous spasm within there too, that doesn't end up making that any better with it. And this can end up being a really with the frequency of World Cups or other competitions, domestic or international, or even then just the training camps and the training that goes along with it, that this can keep it where they have difficulty walking with it as well. That they can also end up having a subluxation of these peroneal tendons where it ends up breaking loose and freeing up from these retinaculum and starts to slip and slide around that lateral malleolus too. Now, this will end up being something where it's the snapping tendon that can end up occurring, that it can end up being this dislocating tendon too, that end up needing some surgical repair for it. But we can also end up doing different rehab and trying to get to that point of where we've relaxed the muscle, we've decreased the inflammation in the tendons. Now, there is such thing as a peroneus cordis for those overachievers where they just have to have a fourth peroneal tendon that's there as well. Well, there's going to be similar mechanics of the sliding and gliding back behind, but it really does insert on that on that lateral portion of the mid-calcaneus with it too, and this cordis comes off from the peroneal brevis. This can end up also causing some additional hypertrophy and of the muscles back behind in that lateral compartment for it. And so patients will end up, or our athletes will end up still having that tenderness, that snapping, that pain with any sort of dorsiflexion and the pinching with it too. Really what we'll end up doing is we'll start off with some basics of trying to make sure that we're covering both the stretching and the range of motion and mobility there. And then what strengthening we can, but it's targeted strengthening across trying to balance out the rest of what's happening at the ankle. Then as an osteopathic physician, I do manipulation, and then I teach, I help to teach any of our MD colleagues that come around and help us from the manipulation standpoint for trampoline and tumbling as well, because if we can free up whatever sort of restrictions there are in that midfoot and also within the talus and the ankle joint itself to allow everything to move more freely as it's supposed to, that can end up helping. That we also end up being able to do a candy cane taping there across that lateral malleolus to help to restrict those peroneal tendons, to help to stabilize that lateral malleolus, that distal fibula as well, to where it doesn't end up getting quite as much of the shearing force with it. But then you also have to end up working with the athlete and the coaches. And the coaches are the ones that have pointed this out as far as their foot on the trampoline bed itself. And if they have a wider stance, they're going to be more prone to this. If they have a more narrow stance, they're going to do better with it. That if they have flat feet, that's going to go ahead and put them into a pronated position anyway, of where there's automatically some pinching that happens from normal foot mechanics there. That we have one athlete with very elite athlete with very flat feet and a wide foot stance on the trampoline bed that has had problems with this. That the Olympic competitor for Great Britain, flattest feet I think I've ever seen with pronation that goes along with it, but he had a more narrow foot imprint on the trampoline bed and did not end up having these problems or any taping or anything otherwise. And so this is where just little things that we can end up doing to try to treat and manage with this too, along with the typical anti-inflammatories. That PRP can also be helpful across here, dry needling as well, cupping, Graston, anything that we can do to try to end up decreasing and the hypertrophy of those muscles and relaxing them as well. So here they are, super happy and jumping. I appreciate y'all letting me be a part of this tonight, and thank you very much.
Thanks so much, Dr. Aldret. Just in the interest of time, we're going to move on now to Dr. Emily Sweeney. So Dr. Sweeney is a pediatric sports medicine physician at Children's Hospital, Colorado, and an associate professor at the CU School of Medicine. She is a former level 10 gymnast who retired at age 16 due to spondylolisthesis. She has coached and judged gymnastics and now focuses her clinical research on spondylolysis and other injuries in gymnastics. She has also started a multidisciplinary clinic specifically for gymnastics, allowing them to see a sports physician, athletic trainer, physical therapist, and dietitian all in the same clinic. In her free time, Emily enjoys CrossFit, hiking, biking, skiing, and spending time with her husband and 2 small children. So Dr. Sweeney, you may go ahead.
Great, thank you. So I know we're ending with everyone's favorite topic, research, but hopefully this won't be too dry. All right, so I do receive funding from AMSSM for this research study that I'm going to talk about here in just a minute. So I started gymnastics at age 4. I got to level 10, as Lauren said. This is me at age 15, somewhere in there. I had a lot of injuries, some of which we've already talked about today. I ended up getting spondy and had spondylolisthesis and had surgery for it. So after I retired at age 16, I started coaching and judging, and then went through my whole medical training while still doing some coaching and judging on the side. And then once I was done with all my PEDS residency and fellowship, I focused my clinic and research on gymnastics. So this is my back not too long ago, so you can see what that looked like. So spondylolysis is a stress fracture of the pars interarticularis. So it's the small little area of the back. It occurs about a third of adolescent athletes who come in with low back pain, so anywhere from 15 to about 50%, but the more recent literature is saying about 20 to 30%. These gymnasts or any athletes will present usually with pain with extension. So my gymnasts usually say my back walkovers hurt or back handsprings hurt, but also impact, like the trampoline athletes when they land really hard. And they're often out of sport for up to 7 months. So that can be quite a long time out of their sport. In addition to just a standard back exam that I would do on any athlete, I always do this stork test, which is here on the left. So I have the athlete stand on one foot, extend backwards, and give them a little rotation to see if that contributes to their pain. And then I also do a prone hyperextension, so just kind of pushing up into a downward or upward dog or cobra pose, and that usually also recreates the pain. And then in my gymnast specifically, Dr. Faustin showed this similar, like a picture of this. So this is me just showing how you can test their shoulder flexion, and you keep your button back up against the wall. I'm doing kind of my best to do it. And I use a cast stick that we have in our clinic, and I make them do it in those 3 positions. That last one, if you imagine a female gymnast trying to do a back walkover on the beam, if they didn't have their hands narrow, that could be a problem and create new issues. So that's a good test to do, because if they don't have good shoulder flexion, they often will then have to use their back to extend more. So you always want to look at the whole chain, not just their back when you're doing an exam. And then this is another test I like to do with my gymnasts. Gymnasts like to use their back extensors to lift their legs up rather than their glutes and hamstrings. The setup is kind of tricky. Sorry, it's noisy. The setup's tricky on this exam. You try to have them go on their knee with their butt on their heel, and then with their hands on their forearm, or their head on their hands, they try to lift their legs straight off the table. And you can see I couldn't even do it on my second leg. So it's really hard to do. After this talk, you guys should all try to do it. Okay, so imaging for spondy, I always get 2-view standing lumbar spine x-rays. It says 10 to 74% of x-rays are positive who have a true spondy. I would say it's closer to 10 to 20% of my spondies actually have something on x-ray. You really need an MRI, I would say, to see this injury, especially if you want to get it early before there's a whole fracture line. So if you think about any bone stress injury, we see that edema first before there's the fracture line. So you can see here, there's edema in the pars, edema here, edema here. We used to get SPECT scans or CT scans, but that's a lot of radiation. In our younger athletes, we don't want to use that. MRI is more expensive, but the MRI is a lot more sensitive for spondies. There's no single management strategy. Everyone does these a little bit differently, but pretty much everyone has some kind of rest. Most people recommend physical therapy. There are certain parts of the country where braces are more commonly used than others. Not a lot of people use bone stimulators. They're not often covered by insurance. And then I recommend screening for REDS or female athlete triad in all these injuries because they are bone stress injuries. So rest, PT, and then treating the underlying issue is key. It's important to note that bony healing doesn't always occur in stress fracture, in the spondylolysis. In most stress fractures it does, but not in spondy. And just because you get bone-to-bone healing doesn't necessarily mean the athlete's gonna have improved pain or be able to return to sport. In addition, doing a long period of rest can lead to atrophy of the muscles, mental health issues, weight gain, and then athletes are out of sport for a long time, so they don't love that. So with that in mind, I will talk about our study here in just a minute. But for our patients who come in, eventually they're going to go to PT. A lot of our gymnasts need to work on these issues. So a lot of them will have tight thoracic and lats, so getting those moving a little bit better. A lot of them have tight pecs, so getting those opened up. So you can see some pictures. I'm using some stuff from Dave Tilley also, so some shift movement science pictures. Those are a great resource. Core control and stability. I never tell my gymnasts they're needing to get stronger or strength, even though it's written here. I tell them to think about stability because most of our high-level gymnasts have a 6 or 8 pack. And so they're like, well, no, I'm strong. But where they're not strong is in those deep core muscles. This is me just tooting my little horn. We did publish these return to sport protocols. So you guys can have access to that if you would like them. You can find them online. But we do have return to gymnastics protocols for men and women for different body parts. And so this is one that I recommend for all my gymnasts when they're coming back from spondies. Okay, I'm going to talk about this last couple minutes, our research study. So this started from some work that was done by my colleagues in Ohio, Dr. Stacy Fisher and Mitch Salhorse. They did a case series looking at 12 athletes in Ohio who had spondy, and they sent these kids immediately to PT. So this immediate functional progression program. So I'm going to talk about IFPP. So they took these kids, put them into PT early, and then they saw how long it took them to get back to sport. They compared that to 121 patients who had standard care, which was different depending on which physician saw them, but it was usually a much longer period of rest. And what they found was that the IFPP group returned to sport about 2 months earlier than the control group. And both groups had similar recurrence of back pain. So we were like, maybe we can get these kids back sooner. So then what we decided to do was submit a grant, get some money, and then we started this prospective study, and we randomized athletes to either start PT right away, that IFPP, or to be in a control group. We enrolled 60, or our goal is to enroll 60 athletes with spondies in Ohio and in Colorado. That control group, remember I said they start PT once pain-free with ADLs after 48 hours. So that may take them 2 days or 2 weeks after diagnosis. It may take 8 weeks after diagnosis. So everyone was a little different. And then the IFPP group had to start PT within a week of diagnosis. And our goal was to compare the safety of IFPP. So we want to make sure this was safe, and then also to compare patient-reported outcomes. The PT protocol was pretty standard. So we trained our PTs at Ohio and Colorado how there's this 3-step-wise progression. And I'm going to kind of just skip through because I know we're running low on time. Our outcome measures we looked at are all listed here, but the ones I'm going to talk about right now are the Micheli Functional Scale. And this is a scale of 0 to 100 that patients report their pain. You want 0, right? That means no pain. We're also looking at time out of sport and recurrence of pain. So that's what I'm going to present right now because we're not fully done with our study still. So far we have 56 athletes, 26 in the intervention group, 30 in the controls. They're about 14 years, and they had about 2 months of pain when they came in to clinic. About 1/3 were female and 2/3 were male, which is pretty similar to other prevalence data for spondy. And then you can see the race breakdown as well. And then their Micheli Functional Scale. So at baseline, they were pretty similar, about 50. But at 1 month, that IFPP group was much lower than the control group. And then by 3 months, they were pretty similar. The return to sport timeline, you can see that the IFPP group took about 73 days, whereas the control group took 105 days to return to sport. So that is statistically significant. Sorry, I don't have a p-value here, but you can see the control group actually had more recurrence of low back pain than our intervention group, which was good for us, but also surprising. And then this just shows how you can see the Micheli Functional Scales trending downwards. So green is the intervention group. So theirs got lower quicker than the control group. So our conclusions are that starting PT immediately in patients with spondy improves their functional ability and really leads to increase or lower rates of pain. And starting PT led to sooner return to sport and fewer recurrences of back pain. So we feel like this is really safe. Our goal is to then eventually do a larger and longer multi-site trial comparing those two groups and potentially a shared decision-making group where we'll make things a little bit different. Some references, and that's all I have.
Just on time. Thanks so much, Dr. Sweeney.
You're
Um,
welcome.
yeah, I mean, so before moving on to the quick Q&A, I just want to thank all of the speakers today for their really interesting presentations and just like sharing part of your evening with some of the residents and the student members. And I know I want to respect everyone's time, so if you have to hop off the call, feel free to do so, but maybe we can do like 5 minutes of Q&A. It looks like we just got a question. Yolanda Pham asks, if a gymnast had an injury during competition, how do you navigate clearing them to return to competition when they may still be safe to compete, but the injury could worsen if they continue? That's a good question. So I guess anyone can take this one.
Sure, I agree. That's a great question, and one of the things that we struggle with in sports medicine all the time. Um, I mean, it depends on what's happening. What some of the harder ones to navigate are something like you suspect a concussion and you need to do, a more thorough assessment than you might have time to do in the middle of a competition. We've actually all collectively have been working on this basically like a medical timeout policy for USA Gymnastics for that very reason, not only suspected concussion, but musculoskeletal injury, because there's not a great mechanism to do that in gymnastics, and no one wants to cost someone the ability to finish their routine if they have to be evaluated. So we've been working for years on establishing a protocol to be able to do that. But, in sports medicine, our job is to make a decision about, is it safe to continue or is it unsafe to continue? And even though that's very hard to tell someone that, that's part of our job as sports medicine physicians and the medical team.
I'm not seeing any other questions right now in the chat. One question that I had though, I'm sure a lot of you guys deal with red S in gymnastics and trampoline, and I was wondering if it seems like some of the panelists are doing research on that, if based on the research, the IOC has like at the Olympic level come up with any initiatives to prevent red S in gymnastics that you may have seen in your time working with Olympic gymnasts?
In terms of the IOC, well, more accurately, the USOPC specifically, there's a lot of push from both a physical and mental health perspective to do screening questionnaires. So there's health histories, part of a pre-participation physical, but sort of beyond that. There's a women's health task force for the USOPC that I serve on, and we're working on a sort of more comprehensive female athlete screen as well that all national team athletes will take and be screened annually, I believe. But we obviously do this within our own team. And Dr. Faustin and I and a sports dietitian from the USOPC for our team specifically have developed some education around the triad and reds. We even did a pre-test, post-test about knowledge from the coaches and the athletes, and presented that data at the Female Athlete Conference 2 years ago. But basically, there were, we always have to look for that and of course talk about it and normalize that discussion. And so really a lot of reds and the triad is often not education or a lack of awareness about how much fueling needs to be happening or whether or not to track cycles, and that may be even a factor in bone stress injuries. So we really focus on starting with education and then following our athletes over time to see if any intervention needs to be done.
Okay, thanks. That makes sense. So just to clarify, that's something that happens more at the team level than at the overall like Olympic USOPC level?
I think it's both.
Okay.
I think I'd add in, Dr. Casey had a great response for that, but I know we're talking about doing this elite level at the Olympic level and these gymnasts, but I think we also have to make sure we're talking about our patients that we see in clinic, right? And the people that are around us, because that education has to come within the community, within coaches, parents, athletes, so that when they actually do get to that Olympic level, they have some awareness about it before they get there, and the interventions can come in. And so we see such a small percentage that we're talking about right now, but we know it impacts across many, many different sports. And education really is the key.
Yeah, it's a really good point. Let's see.
I have a question for Dr. Sweeney. In a situation, can everybody hear me okay?
Yes.
In a situation where you have an athlete that comes in with an injury and you're kind of researching it and you do find like a study or something that shows like yours where it seems like there's pretty clear evidence that there's support for it, but there isn't a large like sample size, like when do you make that decision? Just a shared decision making of when you do that versus like the standard of care? How do you approach that topic?
Yeah. That's a great question, because you can probably find a study that supports almost any, like this or the opposite. So you can find studies that support both a lot of the times. And so I think just if you have an awareness of like what is out in the literature and discussing that with the family, the shared decision making is really important, I think. And I do that a lot. Like I give patients a lot of like say in what we're going to do. Now, obviously, if it's like your leg is broken, you can't do gymnastics right now, right? Like it's straightforward. But no, I think it's really important to talk about it and say, hey, we're learning more, we're trying to figure it out, we think this is safe, and like talk about the risks and benefits of both things. I think is really important. So I think that's, it's a case by case basis for a lot of our athletes.
Awesome, thank you.
Right. Well, I just want to thank all of the panelists again for your presentations today and your time tonight, and all of the residents and student members for attending. And I just want to quickly plug before we end this call that Thursday night at 8:30 p.m. Eastern Time is our next webinar in the series, and that will be textbook injuries with different presenters. So we have Dr. Lauren Elson, who's going to present on dance, Dr. Melody Rubish, who's going to present on breaking, Dr. Pierre Rousier, who will present on yoga, and Dr. Robert O, who's going to present on CrossFit, HIIT, and HIFT. So yeah, thank you guys all again, and have a great night.
Thank you for having us.
Have a good night.
Thank you.
Thank you.
Bye.
Thanks, y'all. That was a lot of fun.